What is hemodynamics? Hemodynamics explains the flow of blood in the blood vessels. Indications for hemodynamic monitoring. Decreased cardiac output. Example, dehydration, GI bleed, hemorrhage, burns or surgery. All types of shock. Example, septic, cardiogenic, or anaphylactic. Deficits or loss of cardiac function. Example, acute MI, cardiomyopathy, or CHF. The heart is divided into right and left side. This is to prevent mixing the deoxygenated blood with the oxygenated blood. The right heart. The right heart consists of the right atrium and ventricle, acting as a single unit. The main function is to receive deoxygenated venous blood into the right atrium. The right ventricle needs to generate only a minimal amount of pressure to pump blood through the pulmonic valve into the pulmonic circulation. It is considered a low-pressure system. The left heart. The left heart consists of the left atrium and ventricle, acting as a single unit. The left heart is a similar unit which receives oxygenated blood from the pulmonary system. The left ventricle needs to generate a greater amount of pressure to pump blood through the aortic valve, into the aorta, and then through the system circulation. It is considered a high-pressure system. Electrical cardiac cycle. The initial phase is depolarization, which begins at the sinus node and spreads a wave of electrical current through the atria, P wave. The second phase occurs when the impulse is carried through the electrical conduction system and transmitted to the ventricles, resulting in systole, QRS complex. The next electrical activity is repolarization, which results in the relaxation of the muscle fibers and produces diastole, ST segment. Autonomic nervous system. The autonomic nervous system stimulates the heart through a balance of sympathetic nervous system and parasympathetic nervous system innervation. The sympathetic nervous system plays a role in speeding up impulse formation, thus increasing the heart rate. The parasympathetic nervous system slows down the heart rate. The heart contracts and relaxes. The contraction called systole, and relaxing called diastole. During the systole, the ventricles contracts, forcing blood into the vessels going to the lungs and body. The ventricles then relax during diastole and filled with blood coming from the upper chamber, which is the right and left atrium. During the systole, the pulmonic and aortic valve opens while the tricuspid valve and mitral valve closes to avoid regurgitation. During diastole, the tricuspid valve and mitral valve opens while the pulmonic and aortic valve closes. Then the cycle starts over again. The heart is being nourished by blood too. Blood vessels like coronary arteries extend over the surface of the heart, branching into a small capillaries. The heart has an electrical conduction which is responsible for keeping it beating. Electrical impulses begin at the SA node, goes to the AV node, then to the Purkinje fibers. This electrical impulse will deliver signal to the ventricles to pump. The conduction system keeps the heart beating in a coordinated and normal rhythm, which in turn keeps blood circulating. Principles of hemodynamics. Number 1. Blood pressure equals cardiac output times systemic vascular resistance. Number 2. Cardiac output equals heart rate times stroke volume. Number 3. Stroke volume is determined by preload, contractility and afterload. Number 4. Bradycardias to tachyarrhythmias that decrease ventricular filling can decrease cardiac output. Cardiac output is the amount of blood that is pumped out of the ventricles in 1 minute. The term is used when discussing the pump effectiveness and ventricular performance of the heart, the cardiac performance. A normal cardiac output is between 4 to 8 liters per minute. To determine cardiac output, multiply heart rate times stroke volume. There is a direct relationship between cardiac output, heart rate, and stroke volume. Therefore, any change in heart rate and/or stroke volume can affect cardiac output. This is an example of how to obtain the cardiac output. Heart rate times stroke volume. For example, if the heart rate is 100 and the stroke volume is 50, multiply 100 to 50 equals 5,000 milliliters, which is 5 liters. Cardiac index, CI, is a hemodynamic measure that relates the cardiac output, CO, to body surface area, BSA. This relates heart performance to the size of the individual. The cardiac index, CI, is usually calculated using the following formula. The unit of measurement is liters per minute per square meter. The normal range of cardiac index at rest is 2.6 to 4.2 liters per minute per square meter. Note: if the CI falls below 1.8, the patient may be in cardiogenic shock. Heart rate. Not only is the rate important, the rhythm can cause hemodynamic imbalances. When the rhythm does not originate from the sinus node, or the rate is too slow or too fast, hemodynamics can be altered. For example, if a patient is in atrial fibrillation, there is a loss of atrial kick and heart rate variability that needs to be taken into consideration. Stroke volume. Stroke volume is the amount of blood pumped out of the ventricle with each contraction. A normal stroke volume is between 60 to 100 ml per beat. This volume can be altered when the heart rate is too fast or the rhythm is too irregular to allow complete filling of the ventricles. Additionally, stroke volume can be abnormal due to the cardiac muscle mass. Stroke volume components. Preload. Preload is the volume required to stretch the cardiac muscle fibers in the atria and ventricles. The cardiac muscle stretches to accommodate the fluid in the chambers. Preload can also be considered filling pressures of the ventricles at end diastole. Preload is measured as central venous pressure for the right side and pulmonary artery wedge pressure for the left side of the heart. Normal CVP is 2 to 8 mm of mercury and PAWP is 4 to 12 mm of mercury. Factors that influence preload are: increases preload, increased circulating volume, mitral valve insufficiency, tap vasoconstrictor use, heart failure, aortic insufficiency. Decreases preload, decreased circulating volume, mitral valve stenosis, vasodilator use, asynchrony of atria and ventricles. Contractility. Contractility is the strength of the cardiac muscle to push blood from the ventricles against the systemic vascular resistance or blood pressure of the patient. Any condition affecting the strength of the cardiac muscle, hypertrophy, will affect stroke volume. Factors that influence contractility are: increases squeeze or contractility. Medications such as positive inotropes. Examples are digoxin, dopamine, dobutamine. Electrolytes such as hypercalcemia. Calcium stimulates the heart to contract. Hyperglycemia. Increased heart rate. Sympathetic stimulation. Decreases or relax contractility. Negative inotropes such as beta blockers, calcium channel blockers, lidocaine, barbiturates. Decreases magnesium, sodium, calcium, increases potassium. Hypoxemia, acidosis, hypercapnia. Stunned heart, scar tissue, hypertrophied muscle. Sustained tachycardia leads to decompensation. Parasympathetic stimulation, vagal stimulation. Afterload is the resistance or pressure the ventricular heart muscle must overcome to open aortic valve and eject volume. Afterload is also known as systemic vascular resistance SVR and pulmonary vascular resistance PVR, the resistance of blood flow through the pulmonary circulation. A normal SVR is 800 to 1200. A normal PVR is 100 to 250. An easy way to estimate increased or decreased afterload is by measuring blood pressure. Hypertension indicates increased SVR and hypotension indicates decreased SVR. Factors that increase afterload are: increases afterload, increases vascular and pulmonary resistance, increased circulating volume, high blood pressure or high systemic vascular resistance, aortic stenosis, myocardial infarction, cardiomyopathy, polycythemia, increased blood viscosity, vasopressor use, decreases afterload, decreases vascular and pulmonary resistance, decreased circulating volume, septic shock, warm phase, aortic insufficiency, decreased cardiac output, end-stage cirrhosis, vasodilator use. Mixed venous oxygen saturation is the measurement of oxygen delivery and oxygen consumption. Oxygen demand is the amount of oxygen the cells and tissues require for their own metabolism. It is the percentage of oxygen bound to hemoglobin in blood returning to the right side of the heart. This reflects the amount of oxygen left over after the tissues remove what they need. It may be used to identify changes in a patient's tissue oxygen extraction. Factors that influence SVO2 are: increases SVO2, decreases body's demand for oxygen, anesthesia, chemical paralysis, increased oxygen saturations, hypothermia, increased cardiac output, increased hemoglobin, sedation. Decreases SVO2, increases body's demand for oxygen, cardiogenic shock, septic shock, decreased cardiac output, decreased hemoglobin, fever, seizures, shivering. To better understand SVO2, let's trace a red blood cell, called ruby. As ruby leaves the body through the left ventricle, it goes into the aorta with an oxygen saturation of 96 to 100%. She branches out with her other red blood cell family into other arteries where they deliver oxygen to the tissues and cells who need it. Then it continues to travel to the arterioles, capillaries, then venules and veins. It finally ends back up into the vena cava, right atrium, right ventricle, and then the pulmonary artery, where before it goes into pulmonary circulation we can take a continuous reading of how much oxygen the arteries used. The normal values of SvO2 are between 60 to 80%. Frank-Starling Law. The Frank-Starling Law states, the greater the stretch, the greater force of the next contraction. To better understand the Frank-Starling Law, let's use the example of the rubber band being the heart's muscle. The less the rubber band is stretched, the less it will propel in the air. The further the rubber band is stretched, the greater the force, and it will propel in the air further. As this relates to preload, if there is too little preload stretch, as in hypovolemia, the heart will not have enough stretch to propel the blood cardiac output through the body. If volume increases, the more preload stretch the heart will have and will contract with more force. In the same manner, if the rubber band is continually, excessively stretched over time, it will lose its elasticity. The heart muscle will wear out and lead to heart failure. I hope you learned from this video. Press subscribe, like and share to support my channel. Press the bell button to be notified with my upcoming videos. Thank you.